So today, in this topic, I'm going to talk about optimization of IPF management in Saudi Arabia. So again, I have nothing to disclose in regard to this topic. And this is my outline. So this is just to remind you that the IPF prognosis is poor, as illustrated in the previous lecture. So unmet needs. So an initiative by 11 European patient advocacy group have identified key themes for unmet needs identified by the patients. These unmet needs are in relation to first the timely and accurate diagnosis, the access to different management forms, including supportive services and end-of-life care, the disease-related education and awareness, and the humanistic burden of ILD. So my talk will be focusing on tackling these unmet needs overall. So toward a better diagnosis, we know that the diagnosis and care pathway of patients with various forms of rare lung disease, including interstitial lung disease, mainly IPF, starts usually with the primary healthcare or the general practitioner. So these professionals stated at the front line need to know how to deal with these kind of comorbidities, since they are dealing with the most common diseases usually. So one of the gaps in dealing with such need is the lack of familiarity with IPF by the general practitioner. So these are the educational needs that needed to be delivered to the frontliners. So more training on rare disease in general, training in genomics and genetic counseling, update about the recent guidelines and management of such diseases, education also on how to communicate the diagnosis and treatment plan, information on the referral network and pathways existed for such disease, and the method to provide such educational needs could include rare disease program, medication curriculum, the post-grad courses, the online educational program, the on-site preceptorship, case-based session with experts, and also rare diseases websites. Another gap in dealing with the lack of in dealing with the diagnostic issues is the delay in diagnosis and or the misdiagnosis. Um, Here in this diagram, we can see that the total delay can be divided into the patient delay and the healthcare delay. So the GP delay, the hospital delay, and the waiting delay from the specialized centers. The second picture showing also the second diagram here showing that this significant delay is persisted among different countries with established ILD or IPF pathway. So the median diagnostic delay reaching up to 1.5 years or up to 2 years in some country. However, of note, in this same article that was published in the BMJ, the timing from imaging until the diagnosis was only 3 months. So that could suggest that maybe putting a certain fast track or pathway once patients have been diagnostic or have found to have some interstitial lung disease on imaging could have a fast track to be evaluated by the pulmonology as a solution to cut off this delay. The third thing is the accessibility to diagnostic testing and the importance of being referred to specialized clinic earlier. And here when we should mention the multidisciplinary discussion as mentioned in details in the previous lecture by Dr. Ghadan. So the role of NDD, as she mentioned, of course, can be precluded to identifying or reaching the diagnosis, evaluation the prognosis, and the crucial role in determining the choice of lung tissue sampling procedure, and possibly genomic classification. And lastly, the impact of multidisciplinary discussion on the management plan. Furthermore, in this illustrated diagram of this study, so the multidisciplinary discussion have not only changed the initial diagnosis, but have an impact on the management lines, including the need for additional supportive services. Specialized clinic. So another aspect to meet the diagnostic there is, we know all, is to refer the patient to specialized clinic. So I think here we need also, as an improvement project in the kingdom, to improve the patient of IPF, to define the specialized clinic. So I found this definition of the specialized clinic by the European Reference Network, where they classify the clinic as specialized clinic if they have some competency requirement, including the in terms of minimum patient number and exposure, and procedure in terms of the clinical assessment tool what that is available in the hospital or the center, and in terms of the human resource requirement. I don't think we have such definition. So establishment such definition could be a great aid in identifying the specialized clinic. What about the outcome from specialized clinic in compared to the non-specialized clinic? So in a large epidemiological study where around 30,000 patients with different ILD subtypes included, the patient with ILD initially managed in the subspecialized center have significant improvement in survival. Not only this, but all-cause mortality or all-cause hospitalization have remarkably improved, especially in patients with idiopathic inflammatory pneumonitis, mainly IPF. Other outcomes in related to the timing of referral, or comparing the timing of referral to specialized clinic. So we can see in the graph on the right, the graph see the time from initial referral to the ILD clinic. The earlier the referral will result in a significant longer time to death or mortality. On the other hand, also in the graph on the left side, patients who have referred earlier to specialized clinic, they are more likely to have a preserved lung function than the patient whom referred late, especially more than 2 years. So these are, in summary, the advantages of early referral to specialized clinics. So there are the expertise and availability of multidisciplinary discussion with the required team members, the close and frequent follow-up for such patients. You have improved survival based on evidence. The possibility of being enrolled in clinical trials also in such center, and the availability of wide supportive services, as we will talk in a moment, that will help in managing these patients. In terms of management, here we should talk about the role of having a registry. So this is another area of improvement which has already been kicked off in the kingdom, led by our group. So registry, the added value of registry data will give us the benefit of having a long-term data for follow-up. We can focus on our population, so we have to study our patient mainly. It can be complementary to clinical trials, an important source for real-world data. So what are the questions and opportunities to be answered or found in registries is the difference between the countries and healthcare system, the insight on the disease progression, again, and real-world data about also the non-pharmacological treatment and management, and better characterization of acute exacerbation, and again, real-world experience in non-IPF fibrotic ILD. What are the challenges of having an IPF registry? So the comparison data of multiple registries, the standardization and harmonization of data, the methodological issue, the missing parameters, and so on, the selection bias. the administrative burden, and of course the funding and cost. So another great service is already established by the Ministry of Health, is the Seha Virtual Clinic, which is or where specific specialties started to have referral to this hospital to provide the best diagnostic and management care. So these are the current specialties that included. I think ILD or IPF mainly could have a role in such a model of care opportunity. So in terms of monitoring IPF patients, of course, the disease is progressive, as mentioned earlier. Our objective is to increase the chance of detect any subtle changes, but clinically relevant deterioration. So this diagram is mainly focusing on what parameters are usually being followed and the frequency. No consensus data on exactly how frequent the patient should be seen. However, clinical assessment include the physical exam, the spirometry, the physiological test, the spirometry, and 6-minute walk test. It is advisable by expert opinions to be done at every 3 to 4 months. In regard to the radiological assessment, it should be individualized based on the patient clinical status and risk for progression. So when talking about monitoring patient with IPF, we should not only just focusing on the clinical and the respiratory status, we should also broaden the picture to look for the patient-reported outcomes. So the patient complaint, the symptoms, basically, the dyspnea, the cough, the fatigue, the deconditioning, the anxiety. And there are many tools that are meant to follow such symptoms. What about the telemedicine and virtual monitoring in IPF? So there is a growing evidence is establishing mainly after the pandemic. So based on survey analysis, a total of 200 clinicians from different countries have been questions about the role of telemedicine in IPF patients. And these were the main purposes of having a patient being followed by virtual visits. It's to it can help in identify the disease progression, they monitor the quality of life, to monitor the use of medication, including the oxygen, to avoid the unnecessary person visit, and to provide early detection of an exacerbation. Furthermore, as a part of assessing the outcome from a telemedicine, overall in this study, it showed that around 60% of the patient being followed virtually have at least one medical decision taken. So there is a rule, and still can be applied in IPF patients. This is an RCT that investigate also whether a home monitoring program improve the health-related quality of life and other outcomes in patients with interstitial lung disease. And we can see here that it did not show significant improvement in the measuring overall the health-related outcome. However, the psychological well-being of the patient has improved in such patient. So the hospitalization did not change. Also, the overall health-related quality measure did not change, but the general well-being of the patient in terms of psychosocial have been improved, and this could be explained due to the frequent monitoring of the patients, and the average number of medication adjusted per patient have also decreased. I think this is sequela of the close follow-up of the patients. What about the patient satisfaction from being monitored virtually? Overall, different studies have shown that the patient satisfaction is high on that manner. So Optimizing the quality of life of patients with IPF, as we mentioned, should be based or should focus on the symptom-centered approach. Again, the dyspnea, the cough, and should focus on the applying the best supportive care, as I mentioned in the next slides. So dyspnea is common in patients with IPF, around 40% at the initial diagnosis, up to 70% after 5 years. Always we should rule out comorbidities causing shortness of breath in such patients, such as primary hypertension, cardiac diseases, muscle disorder, and sleep disorder. Oxygen has been suggested as a potential treatment for dyspnea exertion, especially in the hypoxemic patient. Evidence for benzodiazepines and opioids use still limited. Pulmonary rehabilitation is recommended in the treatment guidelines and showed also improvement in the exercise capacity, dyspnea scores, and the quality of life in patients with IPF. The second most common symptom is the cough, where almost 80% of patients with IPF experience some chronic cough, but the number of patients with severe disabling cough could be lower. So is associated with disease progression. We should exclude and treat the underlying comorbidities. Unfortunately, for the pharmacological treatment has limited evidence till now. What about the breathlessness and the ambulatory oxygen? So the primary goal of using supplemental oxygen in patients with IPF is to protect the organ function, which is the lung, which can potentially enhance the physical functioning and improve the quality of life and survival. So we have the famous Ambox trial, the first randomized control trial of its kind. It demonstrated that the patient with isolated exertional dyspnea, defined as desaturation less than 88 by the 6-minute walk test, whom used the ambulatory oxygen, the lightweight, the 2 kg, had an improvement in their symptoms with the usage of oxygen. However, another aspect of that is sometimes it might provide some anxiety to the patient when they are prescribed oxygen, and on the other hand, causing some limitation in their activities. So almost counseling with the patient is important. Pulmonary rehabilitation, by definition, it should include both the exercise and the educational component, and it's recommended by the international treatment guidelines. So we have a Cochrane review in 2021 that confirms the short-term benefit of the pulmonary rehabilitation in terms of improving the quality of life score, improving the 6-minute walk test distance, and added a new information that this outcome is extended up to 6 to 12 months. It's not only shortened or up to 6 months as the previous studies showed. Also, improvement in dyspnea, improvement in depression score. There is an emergent evidence that they are associated with a survival. Lung transplant, as mentioned earlier, lung transplant evaluation should be conducted at early stage due to the progressive and the unpredictable nature of the disease to improve survival and quality with the transplantation. The early referral enable initiation of patient education in an earlier stage and allow time to address the other medical and psychosocial issues. What about the palliative care and end-of-life care? Despite being recognized as necessity by the patient and the caregiver, the palliative care until now is still not readily available in patients with pulmonary fibrosis, and far less developed in the area in ILD than in oncology, for example. So the main goal of palliative care for patients with ILD is to improve, again, and maintain the quality of life. And studies have shown that it's associated with an improvement in the healthcare quality of life, and it is associated with improved inpatient survival, as illustrated in this study. So, disease-related education and awareness. Again, this is another big unmet needs declared by the patient. and caregiver, not only the patient. So what are the educational needs need to be delivered for this patient? They need a disease-specific information on prognosis and treatment options, practical information. They need up-to-date information on the international levels. It should include the partners or the caregiver. How to improve on such matter is the verbal information from the healthcare provider, the high-quality, regularly updated website, the live educational survey, patient support groups could add again to such manner. So, in summary, taking care or managing an IPF patient is a holistic approach, as mentioned in previous lectures, and should target all of these aspects mentioned again. So, with this, I conclude my talk.